Afternoon. It is afternoon right now. So, welcome to the fifth in our five-session series of the Coding for Value-Based Payment series. And today we're going to be talking about workflow. And I will turn it over to Shelley, who's our presenter.
Perfect. Thank you, guys. So today we're going to talk about coding with confidence, practical solutions for accuracy of your diagnosis codes, and those workflow challenges. So I'm Shelley Sulzberger. I'm a nurse by background, as well as a certified professional coder and an ICD-10 trainer. I work with health centers all over the country, helping them with coding, documentation, compliance processes. So today we've got a lot of information that we're going to talk about. So I may kind of wait until we get towards the end to take questions, just because it's a little more in depth this time. We're going to talk about practical tips and strategies from the beginning to the end to improve the coding process for ICD-10 accuracy to help with value-based care. We'll talk about some common hurdles that you're going to face and how we're going to overcome those. All right, so when we start thinking about value-based care, we really are thinking about your entire team: front desk, clinical staff, the providers, the coders, billing, quality reporting. And so we're going to talk about each of these departments a little more in depth. Okay, so we have to start asking ourselves why front end accuracy really matters in value-based care. Why do we worry about even educating our front end staff? So I'm just going to go ahead and put up a couple of these so we can start talking about them. So accurate demographics, insurance, attribution, they are all the foundation for the correct risk adjustment factor when we're thinking about value-based care. So we need to make sure the right patient is tied to the right provider. Sorry, there we go. Eligibility, accurate demographics. So we really have to start asking ourselves, when we're thinking about the front end, is, are we asking the patient to confirm their email address? Are we asking them to confirm their house address, their phone number, etc.? A lot of times when I sit with front desk, what I hear is everything the same, or is your address still the same? So we need to really move past that and really start making sure that we're asking the patients to give us their address, give us their birth date, etc. Don't give the information for them. Okay, so when we're thinking about front end before the visit, we should start kind of thinking about what we need to obtain from the patient. We should have a checklist, because we want to make sure that we're verifying the foundational information that we need to make sure everything is correct, so that when we start to, number one, bill the patient, but also when we start thinking about value-based care, we have to make sure that we have active insurance. So again, these are things we can do before the visit, because if we're looking at accurate information for our insurance coverage and we need that information, we should be making notes to ask the patient when they come in to give us a copy of their insurance card, if we're not doing that at every single visit. We also need to make sure that we validate that patient identity in the medical record. So how are we making sure we have the right person? And then we have to make sure that we have the eligibility requirements for that visit. Do we have a qualified clinician and a face-to-face encounter? And sometimes what happens is providers or staff get a little hung up on the face-to-face. We can still do telehealth and that still qualifies as a face-to-face encounter currently. All right, so we need to make sure that we have the patient's current insurance coverage. We need to make sure that we have the plan type accurate. So this is taking a little extra time at the front desk to make sure that we're inputting this information correctly, and that we are also not only just looking to see that I have Blue Cross Blue Shield, but do I have the right plan type? Of course, we need to confirm that the primary care provider is correct. And then update and validate those demographics. So, as I said earlier, don't just ask, is your date of birth X? Do you still live at? Let's start making sure that we're asking the patient to give us this information. That last one, gender, make sure that your EMR has the patient's gender in there, because that can also impact value-based care. And while that seems pretty easy and maybe not something that we would miss, I was recently at a health center and the gender was missed and the name could have been male or female. So the medical assistant did all of the work up for the gaps in care for value-based care. And come to find out, all the gaps that were listed were for female, and this person was actually a male, but it was just a name that could be either way. Well, she couldn't figure out why. When she looked, the gender was not updated in the demographic section from the front desk. So kind of in a nutshell, when we're thinking about this, accurate demographics and attribution ensure that we're going to help start driving the correct risk score and quality measures. Obviously, we need information from our providers, but we have to start with the front desk. So don't leave them out. Clinical staff. So we have to start thinking about who is responsible for pre-visit planning. So if you think about pre-visit planning, it is truly a shared responsibility across our team. Providers, clinical staff, coders, etc. So clinical staff should start reviewing the chart in advance. So 2 to 3 days before, who's coming in. Providers should also be reviewing the chart. They're looking for some clinical relevance. Is there any outstanding information that they need prior to the patient coming in? And then, of course, our coders. They can do some pre-visit planning by looking to see who's coming in over the whole health center over the next week or two, and what chronic conditions either need recapturing, or maybe they are not to the highest level of specificity. So like we talked about with chronic kidney disease, when we report unspecified chronic kidney disease, we get 0 for the value-based score. So those are things that the coder should be also looking for, in addition to chronic conditions that need recapture. So really the goal is we want to ensure that our provider walk into the room fully informed and prepared. We also want to make sure that anything our clinical staff can do in advance to help with value-based healthcare is done. Every person should be working to the highest level of their licensure, skill set, and certification. So if we're thinking about some pre-visit planning examples, let's use hypertension. So here we would want to educate our clinical staff, medical assistants, nurses, whoever's doing that pre-visit planning, to review the problem list. Hypertension rarely exists alone. It often clusters with chronic kidney disease, heart disease, nicotine use, etc. So we want to make sure that somebody is looking at the problem list in advance to determine, on all of the patients coming in with hypertension, do they have chronic kidney disease, heart disease? Do we know the stage, or is it listed as unspecified? Also, is there any kind of nicotine dependent use or a history of nicotine? Another example might be if we're thinking about a pre-visit planning for diabetes. We would want our clinical staff to look to see if it's type 1 or type 2. Do they have chronic kidney disease? Do they have any neurological complications? What other underlying comorbidities? What about medication lists? We want to know if they're on a long-term insulin. We want them to look at the surgical history. Do they have an amputation status? Now, amputation status is not only for diabetics, right? Somebody could have gangrene or they could have frostbite where they're having an amputation. But from a pre-visit planning example, it fits very well with diabetes. It's an easy one to look at. We could also include that on our once a year wellness visits where we're looking at the amputation status as well. And then are there some previous labs? So I want to know what the last hemoglobin A1C is, as well as the value and the date. So I want to make sure that we have this information. So this is something that your clinical staff can have ready when they huddle with the provider in the morning. We also want to think about protocols or standing orders. People call them different things, but in a sense, it's when can our staff work ahead? So if we start thinking about clinical protocols, this allows the clinical staff to work in advance and reduce what I would call provider bottlenecks. The protocols really start to empower our clinical team to initiate like certain tests or services before the provider enters the room so that it helps with the workflow efficiency. Also supports value-based care. So when we're thinking about a urinalysis or a hemoglobin A1C or a rapid strep, if rapid flu is another one, pregnancy test, glucose, any of these things that we can do prior to the provider walking in the room, the provider can do a better job with the diagnosis and treatment of this patient. So if we have protocols indicating what signs and symptoms might allow that clinical staff to do a UA in advance or a pregnancy test or a rapid strep, this way our providers go in equipped with all of the information. Also, vaccinations, we could have protocols for those. There's multiple other protocols and standing orders, but this is really a workflow improvement, not extra work, right? So we want to make sure that our protocols are outlined very clear. It helps reduce that provider burden. It shortens the visit time between the providers and the patients, but it also improves the overall flow of our patients being seen. We want to start working with our clinical staff when they're rooming patients. So when you start thinking about value-based care, the medical assistants or nurses or clinical team should really focus on being proactive during rooming the patient to closing the visit. So we're looking at quality gaps, obviously making sure we have an engaged patient, improving that experience. So some key actions that we would expect to find during that rooming, obviously, why is the patient being seen? Some pertinent specific questions, what we would call history of present illness. So if they're coming in for hypertension and they have heart failure, are you seeing cardiology? When was your last appointment? Also validating the medication list. And that does not mean, are your medications the same? It's going through those, making sure our patient knows what they're taking and why they're taking them. Are their vaccines up to date? Are their screenings up to date? At that same time, we're probably doing some PHQ, GAD7 or other screenings, prepare form, whatever needs to be done for that patient. And then really trying to make this patient engagement patient-centered, asking our patient to identify their primary concern. What do you want to get out of the visit? What's the number one thing? We never want to ask our patients, what's the top 2 or 3 things you want to go over? Because once we do that, we pull away from giving the provider anything to pick from. So for example, if we're asking the patients, what's your top 2 or 3 things, they may not be worried about their blood pressure that's 180 over 100. They may not be worried about their legs full of edema or their hemoglobin A1C at 12. So if the patient's number one goal is my toe hurts, we let them address the toe pain, but we also allow our providers to talk about the blood pressure, the diabetes. And when we start to give the patients 2 or 3 or 4 things to pick from, then the provider is running behind because they're trying to address all of the things the patient wanted to address, plus the things that they wanted to address. So as I said earlier, when we're thinking about medication reconciliation, this is really going through and confirming the medications, the dosage, the frequency, making sure the patient knows what medications they take and why they're taking them. We're also closing, as I said, those care gaps. So what kind of outstanding screenings? Do they need a mammogram? When is their colorectal screening due? And thinking about those preventive screening tools. So PHQs, GAD-7s, ASQs, etc. We should be reviewing the past medical, family, and social history. Not has anything changed since your last visit, because they don't even know what's on our EMR from the last visit. So just confirming some of those key things. Taking the vital signs, making sure that we're accurately measuring our vital signs. We're verifying, again, under that social history, smoking status. Some of those things are essential for our quality measures. And then really what I would call just kind of setting the stage for the patient, letting them know that the provider will be in shortly, and then a warm handoff. So a quick 1 minute or less handoff to your provider, highlighting the patient's goals, any critical information. So maybe their blood pressure is elevated, anything like that. We want to make sure that we're handing off to the provider. If we can't do that verbally, we can do it through a chat, a Teams, whatever EMR tools that you have. So when we start to look at workflow, our rooming, vital signs, med reconciliations, screenings, the things we just talked about, goals for the patient. So this is just a cheat sheet. We get to the provider visit, which we're going to talk about, diving a little more into the HPI if it's not where they want it. Obviously, the exam, making sure the documentation supports the meet, making sure the problem list is updated and accurate, and addressing pertinent chronic conditions. And then we want our clinical staff to close the visit or wrap up. And so that's where we're reinforcing education. We're scheduling those follow-ups. We might be doing a patient satisfaction before they leave. And then again, a warm handoff to checkout. This patient needs to come back in 3 months for XYZ. So as I said, kind of what the clinical staff should do, if we're going to kind of summarize, because they set the tone for the visit and they need to make sure the provider has accurate and up-to-date information. Our clinical staff, this workflow we're talking about, directly affects those quality measures as well as patient satisfaction and could impact documentation accuracy. So if you really think about the clinical staff, they are really the bridge between my front desk and my provider. So I need them to scrub the charts a few days in advance, going through whatever pre-visit planning things we're going to do. Some groups pick 1 or 2 things. Some groups pick 3 or 4 things. Start small. Our clinical staff need to be active in the huddle. They should either run it or be an active participant. They should greet the patient, room them professionally, find out why they're here, taking their vitals, making sure the patient and the room are completely ready when that provider walks in. They also need to assist the provider during exams at some time. So maybe a well woman exam. This is where we need our team to really be cognizant. If you know that you're assisting a provider with a well woman exam, for example, you should know about how long before the provider needs you. So say it's 5 minutes, you should be right outside the door. You might be performing ancillary services, labs, immunization, injections. Summarize your visit. Make sure the patient understands. Remember, we have to engage them. Some groups are really starting to do some of those patient satisfaction surveys in the room. And then warm handoff to check out. This patient needs to come back in 3 months for, so that we get that information for the reason for visit when they come next time, so that when we repeat this process of scrubbing the charts, we know why the patient's returning. A big part of value-based care is really patient engagement. So we need to make sure our patients are educated. So clinical staff, if you have pharmacists in your health center, those play a key role with that ongoing patient engagement. So reinforcing education, supporting adherence, helping close any of those care gaps. All of this work, assisting the patient with their appointments, really starts to improve outcomes and supports that value-based care performance. So again, we've got more clinical staff responsibilities. So they have an important job. So when we start thinking about our clinical staff, these responsibilities aren't just like a single step at a time. They're really woven throughout the whole pre-visit planning, rooming, and then what I would call closing the visit. So they all kind of go together. So care gap identification is going to be important. It's one of the most powerful contributions clinical staff can make, because they're often the first one to see those overdue screenings, those missed labs, because they're pre-visit planning and scrubbing that chart. And all of those care gaps directly affect your quality scores and patient outcomes. Performing the social determinants of health screening. Now, we do know that sometimes this is done at the front desk, so it can be done anywhere, but whoever's doing this, we need to make sure that it's getting done, because it helps us understand the patient's barriers. Medication reconciliation. This is a big one. When I shadow clinical staff, a lot of times they'll just say, are you still taking all the same medications? So this is not only a quality cornerstone, but it is also a safety cornerstone. Because if our providers think that we are going through the med list with the patient and we're just asking if everything's the same, then there is a gap. Accurate med lists help prevent errors, and they also support that chronic disease management, as well as improve our quality metrics. So really making sure our team understands the importance and how to really do a medication reconciliation. Risk factors, making sure we're doing our PHQ, our GAD-7. All of these screenings help our providers address risk early. So again, could play an important part of value-based care. And preparing our provider to make sure they adequately capture the HCC codes, which go back to our diagnosis codes for value-based care. So flagging those chronic conditions that might be unspecified, like chronic kidney disease or diabetes, when we have uncomplicated as well as complications. Looking for any abnormal labs or overdue monitoring. Our clinical staff play a huge part in this. And then, as I said earlier, patient engagement. This is where our clinical staff really can shine. So it's reinforcing that education, making sure they know where to get their medications, that they were sent electronically, reminding the patient how important it is to follow up in 3 months, get their labs done. all of those things. So if you really think about it, our clinical staff are the glue that holds the value-based workflow together. Okay, when we start thinking about providers and value-based care, of course, we need our providers to document all of the chronic conditions, but they have to make sure that they use what we call the MEAT. Was it managed, evaluated, assessed, and treated? They need to assign the correct ICD-10 codes. Coders can only code what is documented. If it's not in the note, it doesn't exist. And in a lot of times in our health centers, we don't have coders, or if we do, they don't have time to look at every note and make sure we have the right ICD-10 codes on there. So it is important for our providers to have ongoing training, chart reviews, and education on assigning the correct ICD-10 codes and making sure the documentation supports the MEAT. We also need to make sure that that diagnosis that they're listing is current and relevant, as well as supported. They can't just drop diagnosis in the assessment plan. We also have to make sure, as I said earlier, that there is appropriate documentation for that risk adjustment reporting. When we start thinking about reporting diagnosis, and you keep hearing me say over and over, make sure there's MEAT, make sure their diagnoses are supported, that they're validated. Because if we get an audit from a risk perspective, somebody that's doing one of those risk adjustment audits, they've given you value-based money, and now they're saying, we want to make sure the money we gave you was accurate. And they start looking and find out that we are just pulling in diagnosis without the MEAT, then you might have what we call an overpayment on your value-based money. So it's really educating providers that the MEAT really is the framework that CMS uses to determine whether a diagnosis is valid for risk adjustment, as well as for your E&M code. Providers have to show their clinical thinking. They can't just throw in a diagnosis. If there's a connection, they need to make that connection. So when we start looking at this, we're going to look at symptoms, disease progression, ancillary test, exam findings, maybe medication effectiveness, how they're responding to the treatment, maybe test results. Again, we don't have to have all of these, but we're looking to see, in a nutshell, did the provider evaluate the diagnosis that's listed? And is there a plan for them? Are they managing a medication, getting a lab, sending them somewhere? Or is there a connection? So maybe I don't have any symptoms or any history or exam, but we're looking at a previous lab or a diagnostic result, so I can make the connection. We need our providers to document all cause and effect relationships. Again, there are some where a coder can code those cause and effect together, but a lot of times we don't have a coder in the clinic. And if we do, they don't have time to review every single solitary note. We need our providers to clearly link the complications to any underlying conditions. Again, this helps improve accuracy and prevents undercoding. It helps tell the story. Also, we want to make sure our providers include current diagnosis. We're seeing providers recently starting to document history of when the condition is either resolved or it's an active condition. So in a coding world, history of means we had a condition and it's gone. I had a pneumonia, I was treated, my pneumonia is completely gone. But I'm seeing providers document, for example, history of diabetes, but they're still on a medication. So again, this goes back to making sure that we educate our providers on history of versus active diagnosis. Start thinking about templates and smart phrases. If you already have some, let's go back and look at them to make sure they're accurate. They need to be customized for the patient so they can get us started, but we need to remind providers that they have to customize it for that specific patient. We need them to make sure they are documenting and coding to the highest level of specificity. For example, diabetes, it's not enough, right? When I see that patient has chronic kidney disease, stage 3A or neuropathy, I need that provider to tell me that diagnosis. Diabetes with chronic kidney disease, stage 3A, diabetes with retinopathy, diabetes with neuropathy, chronic conditions. So we need to make sure that we are addressing these at least sometime throughout the year. A lot of times providers are seeing patients every 3 months, maybe every 6 months. There are some when they see them every year, but we need to make sure that we're going through those chronic conditions. We also need to make sure that we're documenting in a timely fashion. And this is one area where providers lose not only on value-based care, but they also lose on E&M. If they wait to document, they don't remember. And so this is where our diagnoses get to be less specific, or we don't include it. And this is where our note doesn't include all of the key elements, that proof of thought, the risk of the patient, the management options. So what not to do? Don't list every single diagnosis at every single visit. Don't use an unspecified code when the specificity is known. So when your note talks about a higher level of specificity, don't pull off your problem list an unspecified code. Don't copy and paste without updating for the specific visit. And don't document history of when my condition is active. Why is this so important? Because if we document a history of and we code a history of, when that actual condition is active, that actual diagnosis may be listed as an HCC code, but when we code it with a history of, we don't get credit for that HCC code, which could bring down your risk adjusted factor score. So let's think about our final assessment checklist. So our assessment is our diagnosis and plan. So we want to make sure that the diagnosis listed are clear, they're to the highest level of specificity, and they match the narrative in the note. So I'm looking for that meet, or I'm looking for that connection. So again, is it monitored, evaluated, assessed, and treated? We also need to start looking to see, is the description in your EMR correct for the ICD-10 code? I am starting to see when I do chart reviews that sometimes the description is very specific, but it is linked to an ICD-10 code that does not match the description. So if you're in billing or coding or quality and you see the description doesn't match, we need to make sure to get that updated because our providers are using that description. And of course, as I said earlier, our providers need to document what I would call the meat for every diagnosis unless we are doing that connection. So what's the provider's responsibility in value-based care? I know we've talked about a lot of these, but we're going to kind of go through here just so you can make sure that you see where we need them to go. We need them to make sure that their documentation supports the meat across the board unless there is a connection. We want them to use the highest level of specificity. So thinking about, is there a cause and effect? Make sure that those diagnoses are done correctly. We need them to address chronic conditions annually. This is super important, especially for that recapture rate. We need to ensure that the documentation matches the assessment. So when I get to my assessment, if I have 5 diagnoses, I either need to make sure all 5 of those were addressed somewhere throughout my note, or I need to make sure there's a connection. And then, of course, I need to make sure that I have the accurate risk adjustment coding. Now, the problem list does matter. So when we think about the problem list, it's really the backbone of accurate documentation and coding. If the problem list is wrong, everything downstream is going to be wrong. Documentation, coding, risk scores, quality measures, all of those are impacted. We need to make sure that the providers own the problem list. They can have their clinical staff help maintain it, but only providers can confirm diagnosis. So we need them to go through and either remove the resolved or inactive diagnosis, make any kind of updates on specificity, or they can direct their team if their health center allows that. But specificity starts with the provider making sure that the problem list is accurate and updated. Make sure that if there are complications or comorbidities, they are linked appropriately to those underlying conditions. We need to make sure that the chronic conditions, as I said earlier, are addressed somewhere in the note. So they're taking their medications, their blood sugar's running this, they don't check their blood pressure, their osteoarthritis is good on their medication, their pain is relatively low, some kind of status of those chronic conditions. And then we need to make sure that our problem list does not include any duplicates or outdated diagnosis. So again, a clean problem list improves workflow, it improves documentation accuracy, and it helps with care gap identification. All right, so our coding and billing staff, when we start thinking about their role in value-based care, we need them to perform periodic documentation checks. A coder's job in a clinic, if you have a coder, cannot be reviewing every single chart. It's too labor intensive and we don't get a lot of return on investment. So setting realistic expectations, like just doing a periodic documentation check, X number of providers, 5 records, whatever you deem is appropriate in your health center. Run reports for unspecified diagnosis. Chronic kidney disease, for example. E66.9 are obesity unspecified. Start identifying patients that are missing relevant specificity, so on their HCC or diagnosis codes. Run reports for patients that are due for their wellness visits. Let's start having somebody contact those individuals. Start having our coding and billing staff provide our providers with short, targeted education. It is much more effective to do short, targeted education than a long training session. So provide quick tips. Maybe take a documentation example. Maybe you take one that's not so great and one that is much better. or use that same example to show weak documentation versus strong documentation. And of course, support accurate risk adjustment. So again, this reinforces providers still must document the meat and specificity of our diagnosis. Then once we start looking at kind of what I would call the workflow map from every area we've talked about, we start to look at, as I said at the beginning, front desk. This is really where we're getting our data integrity, because that is one piece of value-based healthcare, is we have to have the patient's demographics, that information. And so we've talked about making sure we have the demographics accurate, the insurance correct, the appropriate primary care provider assigned to that patient. We come along, and then our clinical staff should be doing some pre-visit planning. Who's coming in? Why are they coming in? Looking at their problem list for those key items. Are there unspecified and more specific diagnoses listed? Looking at the care gaps. Do we have protocols that we can do for a specific patient before the provider walks in the room? I should be pre-visit planning all of that so I am ready when that patient walks in. Provider, they're really kind of the documentation and decision-making portion, right? So they're assessing and managing conditions using the MEAT: monitored, evaluated, assessed, and treated. They're updating the problem list. They are documenting to the highest level of specificity. Our coder and billing team. So they're reviewing and reporting, running targeted reports. Who's due for their wellness? Chronic kidney disease unspecified, obesity unspecified. So they're looking to figure out who is under reported and giving that information to providers to see if we can find a better or more specific diagnosis. And then our billing and quality teams. They are submitting claims, validating coding accuracy, and that could be your coder or your quality team, your billing team, depending on what you're looking for. We're ensuring that we're meeting our quality measures and our risk scores are all being captured appropriately. So if we've had kind of what I would call a cheat sheet, again, this is not all inclusive, but who owns what? Front desk? Everybody should be pre-visit planning. You can see that. Front desk owns the demographics. My clinical staff owns standing orders. They have some documentation. And starting to look at that problem list for accuracy. My providers, everybody should have pre-visit planning. Documenting, coding, problem list. My coders, pre-visit planning and coding. So let's talk about some workflow barriers. Barriers are time, knowledge, and EMR limitations. So when we start thinking about time, our providers are under constant time pressure, which leads them to what? Shortcuts in documentation, unspecified diagnosis codes, not painting a picture, not telling us their proof of thought, not describing how complex their patients are because they don't have time. We also know it's limited knowledge. Many providers never received formal ICD-10 training or risk adjustment training. A lot of times it's just they've heard a little bit, but they don't really understand the whole process. So if there's a decision tree in their EMR, they also may not understand that one. They don't understand the logic. It's unclear to them because nobody's gone through it with them. Or if they did, it was only for a short time. There might not be a clear decision tree to help them get to the highest level specificity. And then, of course, we know our electronic health record sometimes can make it difficult to find the correct code. So they might type in something, but it doesn't give them what they're looking for. Sometimes there are so many descriptions tied to an ICD-10 number, they're not sure because it causes confusion. So this is a workflow problem, not a provider problem. So we need to make sure to try to make our tools a little more user-friendly. Other ways that our health record can hurt us, some of the tools, they have auto-populated diagnosis, or they might be putting 2 or 3 diagnoses together and they auto-populate. Sometimes the mapped codes are not mapped correctly. Templates that are being pulled forward include old diagnoses because they were created a long time ago and nobody goes back to update them. Or it defaults automatically to an unspecified code. Other barriers related to support, communication, and feedback. Providers need ongoing support, not a one-time training. So we have to do those short targeted education I talked about earlier. We need to give them coding and billing resources. And we know providers are stretched thin. So we need to make sure that they have coding and billing resources that are easy for them to follow. We have fragmented communication. So a lot of times there's a communication gap between providers and coders or billers. So then it starts to cause documentation errors or issues. And our providers see coding as what they would call busy work. Again, it's because they don't receive timely, meaningful feedback. So providers say, I never hear from coding and billing. I assume I'm doing okay. I have no idea. So again, we want to make sure that we have better communication. So let's talk about some solutions. So first of all, we need to make sure that our coders or billers and providers collaborate. They cannot operate in a silo. So we've got to come up with a really good defined communication process because that reduces confusion. It improves accuracy, but it also improves that relationship. Our health record optimization. We've got to start improving interface and usability. So better favorite list, better templates, better prompt. All of those things are going to help reduce provider burden. We need to have ongoing education on ICD-10 codes. We want to do short, targeted trainings. They are much more effective than long trainings. We lose our providers. We also want to start embedding maybe some alerts or nudges for clinical documentation improvement. So solutions for feedback systems and huddles. We need monthly reports. They help providers see trend and improve documentation. But we need to educate our providers on how to read those monthly reports. We need to do coding and documentation reviews to identify gaps before a true audit from a payer does. That means we have to educate our providers on the coding and documentation reviews, even if they've done well. Shadow providers. Number one, it builds empathy between the coder and the provider. It shows that they're starting to build a relationship, and it allows that immediate feedback to the provider when they come out of the room. Regular huddles. This helps the teams address complex patient and care gaps proactively. So pull together a clinical person, a provider, somebody from the front desk, somebody from coding and billing, somebody from quality. We should be discussing those complex complex patients, as well as the care gaps during those huddles. So social determinants of health, while they may not be on Medicare's ACO for risk-adjusted factor, many other payers have them included as part of their value-based, but they also really do help determine the complexity of your patients. So here are some categories for those social determinants of health. We know that these barriers do impact outcomes for the patients. So as I said, they don't increase our RAF score, but they do improve care coordination, reporting, resource allocation. So it's really important we start educating our providers on these Z codes. So some commonly used ones are homelessness. And again, there are multiple codes under that: unspecified, sheltered, unsheltered, lack of drinking water, problems related to unemployment. So documentation can be simple, but we just need the provider to include the diagnosis and then kind of what's the plan or intervention, referring them to a social worker, a health educator, etc. So if we look at this example, we've got a 22-year-old who comes in for ADHD. Her history is significant for insomnia and ADHD. Unfortunately, in early February, they had a house fire. They've been living separately. They still have several of her medications, but she's been without her Ritalin. So this example shows us how the social determinants of health naturally appear in a narrative note. So again, providers don't need a lot of information because we can support inadequate housing for this encounter. So again, some best practices: start integrating our screening tools. Prepare PHQ, train our providers on how to document social determinants of health in a simple, natural way. And again, have our EMR prompts or templates help us ensure that those are not overlooked. So some final thoughts. This is really just to give you kind of a workflow picture, I guess you'll call it, related to what's clinical, what's related to documentation, and what's related to communication. You guys can read these. So we have to start thinking about what can be delegated. And shadowing also helps. Many times I find providers doing things that could be shifted to someone else: clinical staff, care managers. There could be clinical staff doing work that could be shifted to front desk. So really thinking about that. Looking at your workflow, thinking about redesign to improve efficiency and documentation quality, and really starting to define roles for everybody. The goal is really to let providers focus on clinical decision-making. Of course, etiology and manifestation rules require coding both conditions when appropriate. So this is where we need some of those prompts in our EHR, because providers don't always know when we need two codes. There's some excludes and excludes 1 and 2 notes that are super important. They can cause coding errors and kickbacks. So again, the more we can set up some of those nudges or alerts in our EHR, the better. Making sure our providers know how to code for malignancies. Again, we could have some nudges in our EHR. Is it a current malignancy or a history of? And then, of course, specificity, making sure that the meat is all there, or there is some kind of what I would call connection between the diagnosis and the separate diagnosis that there might not be any meat on. Okay, I know that's a lot of information in a short amount of time. So I think really the best practice, and then I'll open it up to questions, is really start looking at your workflow between the front desk, your clinical team, your providers, and your coding and billing team. Just sitting and watching the process, and then start taking some notes and going back to this presentation to see what can we do better for value-based care, but also good patient care and patient flow, because it'll help the whole health system from the beginning to the end if we have better processes in place. Okay, so I'm going to open it up to questions, comments. And if you have questions from one of the other trainings or anything, even if it's not about value-based healthcare, I am happy to answer those questions as well. And if you have a question, make sure you ask it. You can come off mute or you can type it in the chat, because if you're thinking of that question, I can guarantee you someone else is thinking, they just don't want to ask the question. Any questions at all? You guys are really quiet today.
Definitely a quiet group.
Yes.
You must have just explained it perfectly.
Oh, I'm sure. There's always a question.
I
Somebody
know,
ask a
I know.
question. All right. Well, if you don't have any questions, then kind of what I'll tell you is you can only eat an elephant one bite at a time. So pick a starting point and really work on that one spot and get really good at that. And then go to the next, because you can't do everything at one time. If you start thinking that way, then you're going to get overwhelmed and you're not going to follow through. So you can assign different people. So maybe you assign somebody, hey, you evaluate the front desk, I'll evaluate the clinical team. You can divide and conquer, but remember, just go slow.
Well, thank you, Shelley. We got a couple of really good comments in the chat, just thanking you for the information.
Perfect. Thank
Um,
you.
we did record this, and it will take a couple of days, maybe early next week, but we will get the slides, any materials, and the recording link out to everyone.
And if you guys can please complete the evaluation. I know that this helps Terry and her team, but it also helps me as a speaker. So if you guys can answer, go through and do the evaluation, that is super helpful for everyone. All right, guys, thank you. Have a great day.
You too.